So we'll move our attention over to the Achilles, away from impingements and unstable ankles. And this lecture series is all about new technologies and innovation in orthopedics. So today we're going to talk about a new kind of thing that's exciting our world of sports medicine and musculoskeletal medicine in terms of what you can do via percutaneous or just through the skin procedures using ultrasound. So just a little bit about me. I predominantly work in sports. I'm a sports medicine doctor, mainly working with tennis players at British Tennis. I also work at London Bridge, like Sam said. And I do a little bit of lecturing at King's College London. I don't have any, we're discussing a lot of new technologies here, but I don't have any competing interests or disclosures. Let's start off with a bit of history, right? We all think it's important to understand where medicines come from. What was the first reported Achilles injury? Has anyone seen QI when it goes straight away? It's not Achilles. Who had one before Achilles? Not quite Roman. So if you read the Iliad by Homer, Achilles actually bound Hector by the Achilles and drove him around, when he killed him after his famous Trojan nemesis, drove him around the stadium bound to the back of the chariot. So that actually was the first reported Achilles injury. And Achilles, quite ironically, got shot in the Achilles about 2-3 weeks later. And that was his injury there. So, that's where Achilles injuries really started. That's how we still coined the term Achilles from there. And then, anyone know who this is? Not Homer. Definitely not Homer Simpson. It's either going to be Hippocrates or Socrates, isn't it? But it's actually Hippocrates. So, the forefather of modern medicine, he was the first one who coined the term sort of Achilles tendon, or tendo magnus is what he called it. And actually, no one really knew what the Achilles was. It was like, is it a heel? Is it the tendon? What's going on there? And it wasn't until this Flemish anatomist, Philip Verheyen, actually coined the term Achilles tendon. So that was, you had to wait all past the Dark Ages, the sort of 1500s. And then we started getting a bit more specific about our diagnosis. French surgeon, Ambroise Paré, so he basically described the first Achilles tendon injury in one of his medical journals. That was a closed injury where the Achilles tendon had essentially ruptured. And he was the first one to actually medically document that there has been an Achilles tendon injury. Alexander Monro, he is a Scottish surgeon who actually founded Edinburgh Medical School. So he created this kind of rather fancy stocking device, which could be described as one of the first Aquinas casters. And basically he said, look, actually, if I put my foot into a bit of a plantar flex position and leave it there, he injured his Achilles, and he did that to himself. And that became the first kind of casting that came about. And that was, not until the sort of 1700s. And it really wasn't until sort of 1920s, 1930s until we started got bigger case series, 20, 30 patients and together. And then we started arguing about, okay, what's better? Is it surgically managed? Is it conservatively managed for Achilles tendon ruptures and Achilles tendon injuries? And we still kind of have that debate today about, what is the best way to treat an Achilles tendon injury? So, leaving injury aside, we're moving a bit more onto tendinopathy, right? So I think most of us here would agree that there's 3 kind of key cornerstones in Achilles tendinopathy management, right? So you've got the principles of rehabilitation. So somewhere, where I'm sure we're all advocates for in this room, making sure that load management is properly managed, so they're not doing too much activity, they're doing the right type of activity. We have to credit Alfredson with his first eccentric loading program and just going through how you might want to load and exercise the Achilles tendon if it's tendinopathic. Soft tissue, so great studies of celiacs, I'm sure we all hear, but making sure you have the right soft tissue interventions, instrument assisted, for example, or non-instrument assisted. Things have moved on, and then over the past 20 years or so, we've come to more injection-based therapies. So the advent of platelet cells and autologous blood injections and stem cells. We moved on to things like high-volume injections, as well as percutaneous treatments, and that's the kind of what we're going to be discussing a bit more in detail today. Surgical management has its place in Achilles tendinopathy as well. So this procedure at the top here is quite a novel technique where you'd have a radiologist or sports medicine physician, for example, in theatre with the surgeon, guiding the surgeon on how to do an intervention through the skin and getting the key targets, really, assessing the key injured areas using ultrasound. So that's a kind of technique that's coming out as well. And then, of course, you've got open surgical debridement, or a bit more invasive for quite more severe cases. Shockwave therapy is also on here, and shockwave is a great adjunct for any of these therapies, really. And I'm sure most of us have been using shockwave or have at least heard of it. What's happening across the pond and what's the new innovation? So we're all becoming more familiar with high volume injections. Has anyone heard of high or referred to a high volume injection? So the science behind high volume injections is essentially you're trying to disrupt the interface between Kager's fat pad and the Achilles tendon, because the science is there's lots of blood vessel formation that goes from Kager's into the Achilles tendon, and what follows blood vessels? Nerve fibers. So actually, if you're trying to rehabilitate Achilles tendon, you want to kind of strip that area, get the patient pain-free, and get them exercising properly. So it's a very common procedure we do these days in most outpatient clinics. You can see the Achilles tendon here and the needle coming in. This is a cross-sectional view. So you're putting fluid around the Achilles tendon, around into the paratenon, and it's kind of stripping the tendon. And patients usually feel great after that, and they can come back to the physio colleagues and rehab very well. So this is great, and this is really helping us with Achilles tendonitis management. However, it's not very useful if you've got lesions and problems inside the tendon itself. So the latest interventions that are happening mainly across the other side of the pond by our American colleagues are these things to do with ultrasound-guided percutaneous tenotomy. It's a bit of a mouthful, but they've classified it PUT, so percutaneous ultrasound-guided tenotomy. And basically what you do, you're having a new device here that can have multiple functions. So it can inject, it can suck, and it can debride using ultrasound sonic waves. So actually what you're getting is a small incision that can be done in an outpatient setting, and you can go into the tendon, you can debride using ultrasound at the same time, you can debride calcific deposits, you can try to remove scar tissue, you could try to remove inflamed areas of tissue, and really be guided about how you're treating the Achilles tendon, all in a very nice outpatient setting. So what you will see here is that there'll be he's scanning the tendon, he's doing some local anesthetic just to numb the area where the incision will be, and then he'll make a very tiny incision using a scalpel, and it only needs to be about less than a centimetre big, which could be quite easily steri-stripped after. And then what happens is he gets the probe and he's debriding the area. So this is what it looks like on ultrasound. The needle's coming in. It's a fairly, not overly big needle, but 18 gauge, 20 gauge, and you can really target the calcific deposits. So this is the heel bone here. This is the insertion of the Achilles, and you can be really specific about what you're treating from that point of view. Sucking out all these little bits, washing them away, and also using other techniques to kind of debride them. What can you treat with it? What does the evidence show? Actually, when we're trying to treat an Achilles tendon, we're trying to decide what is the pathology behind the tendon. Is it inflamed? Is it thickened? Is there loads of calcium in it? Is there a bursitis? Is there localized lesions? Is there a tear? Is there a paratendonitis? So actually, ultrasound gives you that evidence and specific targets, and then it's up to you to choose the right settings and the right diagnostics, really, to try and help you. And using PUT, you can target these lesions specifically. So calcific deposits, isolated lesions, and bursectomies. So retrocalcaneal bursa, which will sit right here, you can get in there, aspirate the bursa, and then debride it. Particularly important for people who may have inflammatory conditions or inflammatory Achilles tendon, where you may get a bit of a thickened bursa as well. This is an example of PUT in use. So for example, you can break down an inflamed Achilles tendon here, and then it comes up in about 6 months' time. Of course, making sure rehab is going and the optimal loading, and you've sorted out all the other exercise implications. The tendon generally regenerates and looks much better. So, a new evolving science, what are the pros and cons? I think Well, like any new technology, it needs to be tried and tested. There's not enough evidence, really, and not enough big patient case studies and case cohorts to say actually whether this is going to work in the longer term, and actually how bashing with this probe and with this new type of needle will actually injure the tendon or cause it to heal in the longer term. But evidence out there suggests that actually it could be very, very worthwhile and a good adjunct before you get to the surgical stages. It avoids open procedures. You can use ultrasound to really guide you in how you get on. You can do it under local. It's outpatient based. It's not just radiologists to do this. It might be sports medicine physicians. It might be physiotherapists who are appropriately trained. Very, very accessible technology. So there we go. We are hopefully trialing this at London Bridge. So if you're interested in coming and having a look, please do come visit. And if you want to get in touch with any other questions, please do get in touch with me. Thank you very much.